Welcome everyone to today's webinar. I am Mackenzie Bean with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. James Woodson is a board-certified emergency physician who completed his training at Carolina's Medical Center. While practicing, he experienced the communication difficulties we face in healthcare in diverse settings, from rural critical access facilities all the way to major metropolitan tertiary care centers. This experience inspired Dr. Woodson to found the healthcare communication company Pulsera, where he currently serves as CEO. Dr. William K. Atkinson is president of Raleigh, North Carolina-based Godon Healthcare Consulting. He is the former president and CEO of hospitals and healthcare systems in North Carolina, South Carolina, Texas, and Colorado. He is past chairman of the North Carolina Hospital Association, the North Carolina Institute of Medicine, and the North Carolina Center for Healthcare Quality and Safety. Dr. Atkinson also serves on the State of North Carolina EMS Advisory Board. Dr. Atkinson, I'll now turn the floor over to you.
Well, good morning and welcome to our webinar this morning. Dr. Woodson and I are glad to meet with you. We're going to talk about complexity today, and basically the quality or state of being complex. And if you look at here to the bottom of this photograph, the where, when, how, what, who, and why of healthcare. Anyone who's been in an EMS setting or in a rural hospital or an urban hospital or a complex university medical center understands that complexity is just part of the normal situation we deal with, and our intent is to help take away some of that complexity. Next slide. Having been in EMS and having still been involved, we all know this picture. It's that EMS has emerged into a team response, and you have fire, police, individual EMS systems that are involved. And this is not unlike what happens in hospitals, but just on a much larger scale. And so we're really talking about today communications, quick and meaningful communications. Next slide. And these are pictures that actually were taken by some of my staff when I was president of WakeMed Health and Hospitals in Raleigh, North Carolina. And this is just an example. The picture to the left is a call up for a trauma call, a real trauma call, and just the number of people who are standing by here for the arrival of the first patients that were coming into the trauma center at WakeMed. To the right is a critical care operating room getting ready to do a major procedure. And if you look at the things on this list, all of these involve a sophisticated response, tremendous amounts of equipment and supplies, and people that come from all types of places to stand ready to help. Time matters, but these are just two real-world captured pictures of people awaiting the start of the delivery of a trauma patient to care. Next slide. As all of us know who have been involved in emergency medicine or emergency care, time matters. We used to think about the golden hour in trauma. We know that term, and we know it now in so many other areas. And what Pulsera is about, and what Dr. Woodson and his team have created, is a solution, or at least a great start on the solution of dealing with the question of critical time in medical and surgical emergencies. Next slide. Real-time and meaningful communication is extremely important, and I don't know anybody who's been involved in healthcare very long who hadn't seen a situation where everything was ready to go, but the communications was just not right. And as a result, much of the effort that could have been used to the benefit of a patient or otherwise, even to the teams, has been lost simply because of communication failures. And again, that's what we're talking about today. Next slide. Healthcare cost, which we hear about in the media and all of us know to be a reality, is the meter is simply running 24/7, 365, and that's true in emergency response agencies, be they fire or police or EMS or other types of agencies that are involved in medical and surgical and trauma emergencies. It's also true in hospitals. And one of the ways hospitals address cost is not necessarily to have every single person who is going to be involved in a critical case on standby physically in the hospital. They have to be notified and have to be given good information because they're otherwise busy. And so in fairness to address cost, you have to have a common sense approach to coordination of communications. And again, we'll be talking about that today. Next slide. And for anybody that's been out on an ambulance and spent any time there, you understand that the EMS and operational reality is complex. And when you think about responding to a call, most people just generally think it's the call up the street from the fire station or the EMS station. But the reality is EMS operations are complex. And in this case, a picture is worth 1,000 words. It's just not easy, and there are time factors. Even with the best of EMS systems, there are time factors that influence the delivery of a patient. Communications has to start immediately, and the teams have to be notified immediately because there may be delays in the transport of the patient. Next slide.
All right, well, thank you, Dr. Atkinson. So I appreciate you joining us today and everybody joining us on the webinar today. So I want to kind of pause for a second and see if you guys recognize any of these words on this screen right now. So obviously these are a lot of buzzwords that are out there. So every administrator or board member, any advocate is really trying to work towards these goals. And of course, every vendor is going to promise that they will help you deliver these. So I don't want to minimize these because they're fantastic, but achieving any of the things listed on this screen really assumes that we are all working together. So everyone in a region, every EMS agency, every hospital. Even more complex is starting to get to every payer, every policy on down the line. So how far from reality is this though? So many of us are trying to address these issues with things like interoperability of data. This is very, very important. It's taken a lot of our time, attention, money, and those type of things, but is interoperability of data enough? Are EHRs enough? There's many more reasons than just pursuing these things on the screen, but some systems are trying to address the scenario that they're facing with consolidation. So either trying to own the entire or at least more of the patient journey will help them achieve some of these goals. So another question that I'd ask is, will consolidation alone let you address these problems in full? Can you even own the entire patient journey? So what we propose really is the reality is that our healthcare system is fragmented. So regions will either tend to have, like in metro areas, many healthcare entities or systems that own a lot of the resources, and so therefore they're competing with each other. In many rural areas, you actually have lack of resources where they can't basically take care of the patient by themselves. You can also look at the technologies that we use. So the technologies that we use and purchase are typically only used in our system. So picture a metropolitan area with 30 hospitals and 60 EMS agencies. How many technologies are used in that metro area? How many EPCRs, EHRs, how many communication solutions are being used? So consolidation alone will not solve this problem. So think about it. Consolidation will actually create fewer silos, but those silos will have thicker walls. So the question is, well, what can I do about it? And that's what we're going to talk about and look at some today. So there are some implications to the technologies that we use or how we use them, maybe plugging the technologies into networks or platforms. But probably more importantly, I think some of the lessons that we're going to learn today and look at, there are implications on how we think about our patients, how we build and educate our care teams. So with that, one of the things that we believe here at Pulsera is you can fill in the blank buzzword. Take patient safety, for instance. It's often determined more by what we do together rather than by what we accomplish for our patients in our own individual silos. So I'm one of those eternal optimists out there. I'm amazed at all the people and technology that we have access to in healthcare. But imagine what we could do together if we actually work together. So it's not just about the patient outcomes, but I personally believe we don't need to spend 20% of GDP on healthcare. So if you believe this, there are implications, whether it's at a regional level, state level, whether it's at an individual EMS agency or hospital or health system level, or just at an individual or personal level. So today what we want to focus on is one of the major influencers of some of these big buzzwords that we're looking at. Communication, and more specifically, we want to look at team communication. Because like it or not, healthcare is a team sport. So when you're looking at team communication in healthcare, I'd like you to kind of take a step back and picture a team sport like football or basketball or something like that. Look at the way that we communicate in healthcare and see if a team sport would actually practice their craft the way that we communicate in healthcare. So with that, we'll kind of start off with patient safety. So a lot of you guys who know us already know we spend a lot of time focused on patient safety. I believe this is a good illustration of the value that we can present when we work together. So if you look at medical errors and miscommunication, you guys know the stats that up to 400,000 people a year are killed by medical errors. We're actually the third leading cause of death. On top of that, 10,000 serious medical complications every single day. On top of that, what about all the treatment delays that have many downstream effects on morbidity and mortality? When you take a step back and look at these, studies show that 80% of these are miscommunication between caregivers during transitions of care. So that's really, really important for us to look at, miscommunication during transitions of care. So I think it might be time for us to take a step back with the technologies we actually have today and even look at what does a handoff mean? What does a transition of care mean? I've spent a ton of time reviewing cases for malpractice claims, that kind of stuff, and a significant portion of these, there were bits and elements of the information, wisdom, knowledge, that kind of stuff that were known by early care providers but weren't translated downstream to the other care team members. So it kind of begs the question, do we need to just hand off to the first person that we see, or is it our responsibility to be able to transmit some of this information real time downstream? So one of the things that we want to do is really look at the problem and expand the problem a little bit more. So one of the key problems that we believe we face in healthcare is patient-centric healthcare as we currently practice it is a failed philosophy. So that sounds kind of weird, right? That's the exact opposite of what we're being taught out there. And I think this is a very, very important point, because one of the things that we do as healthcare providers, we often focus on the patient, the tasks, the to-do list, the team members immediately in front of us, when the reality is downstream there's a lot of care providers that we need to be focused on. So we need to not only focus on the patient, but understand the patient journey and have a global understanding of the downstream team members. Imagine that sports team that you're only focused on the player that has the ball. That sounds ridiculous, right? You have to see and know everything that's going on downstream. So imagine especially a time-sensitive emergency where there's multiple handoffs in a very short period of time. Picture a EMS provider who basically only focuses on the patient in front of them. If they do that, then they could miss the opportunity of spending 5, 10, 20, 30 seconds doing something that could actually have an effect for 20 minutes of the overall patient treatment time because of what they set in motion downstream. The same is true for people like me in the emergency department. The same is true for communication with the downstream specialists. So the second problem we want to kind of dig into a little bit is look at all the archaic communication technologies we use. So in 2018, If you're having a heart attack, we may use an old-fashioned modem, radios, distribute the ECG through things like email, blast email, or fax machine, maybe a blinking computer over in the corner. Then we're using pagers, phones, a ton of middlemen, secure messaging, non-secure messaging, tons and tons of different communication technologies. If you look at the way these communication technologies work, many of them are one-to-one communication, meaning that I can only get two people to communicate at the same time, or it's a one-to-many like a blast page, so it's just a blast transmission of information. So have you ever played that telephone game at camp where you whisper something in someone's ear and then downstream you wait until it passes through the entire group around the campfire, and what happens at the end? Some bizarre story is what was told. So what happens in critical care communications, especially when you're reliant on one-to-one communication, when one link in that chain breaks? So another question that we have to ask is, in the days of interoperability, and that's what we're talking about all the time, are these technologies interoperable? Well, obviously not. No. How is a fax machine interoperable with a telephone? They're just not. Most of the communication that we relay in real time nowadays is vapor. Basically, it's said and then it just disappears. And so we repeat the same thing over and over and over again. And half the time, by the time the information gets downstream, it's outdated. And so the end result really is our teams are in silos. So this is true when crossing departments within our own hospital, or in the image here, going from one floor to the other. But it's especially true when you're talking about bridging these different silos, i.e. crossing different healthcare entities. So what's even more important, the way that we think about this with regions is we often try to evaluate and solve these problems in silos. So we may look at pre-hospital communication and focus on just that, or just interfacility communication and just focus on that. We're not taking a step back and trying to unite these. So a few examples, you can look at things like STEMI care. We'll go back to this slide. So we'll focus on pre-hospital transmission of an ECG. We'll spend $10,000 to $15,000 a year just working on that, when only half of our patients come in by EMS. What about the other half? What about stroke patients, where up to half of these are doing interfacility transfers? And then we'll come back and focus on just the patient radio report. No wonder we struggle with things like turnaround times and handoffs and efficiencies and all those type of things. Other things that we focus on, you can look at just intrafacility communication. There's a whole space called clinical communication and collaboration. There's a bunch of these programs out here. In fact, most of our hospitals that use Pulsera actually have one of these solutions. And these are fantastic, and in my opinion, they're very, very needed. But they can't communicate and coordinate care from the pre-hospital space and continue it to the intrafacility space. And then if the patient needs to be transferred, involve the next EMS agency, involve the next hospital. They just aren't set up to do that. And so I think that's really important for us to look at, that the current solutions that we're looking at really, or that we deploy in our systems, really aren't set up to be able to manage these. You can look at things like interfacility communication, and I believe transfer centers are fantastic. But if you look at getting this clinician with this clinician, how do you connect them? It's basically routed through a transfer center using a telephone. And if you've ever been on the receiving end of one of these things, it's incredibly frustrating sitting there on hold. So we either do connect these people with a telephone, or sometimes we use telemedicine solutions that have very fixed endpoints, instead of really a dynamic team that can be constantly built, and anyone on that team having video capabilities. So we'll ask another question here, which is, can EHRs solve this problem for real-time communication? So even if it crosses all healthcare entities, we wave a magic wand, and interoperability is supreme. It works perfectly. Well, I think we need to take a step back and really analyze that question, because this is one of the common things that a lot of people really get confused on, is can our EHRs solve this problem? Well, one of the things I like to take a step back and is ask the question, well, what do we communicate? Well, we communicate data, obviously, right? so EHRs are great at data. Well, hopefully we don't just communicate data. Hopefully we're also communicating information, knowledge, wisdom, those type of things to other care providers. So a couple of brief comments. Number one is we have a data entry problem in healthcare. I haven't talked to a single clinician that doesn't agree with that statement. It takes too long to enter structured data into our EHRs so that it's not available for real-time communication. It's just not there. The second issue is EHR is good at storing data, or EPCRs are good at storing data, but it's not great at storing information, knowledge, wisdom, and especially it's not good at communicating those. And so at the end of the day, I don't believe EHRs are going to be basically our communication tools. Not in the near term, it's just not possible. So at the end of the day, the people are still delivering the care. They're still having conversations, and we need to connect them. We need to really accept the fact that moving data around is not the same thing as communicating. And so at this point, I like to kind of take a step back, and people will say, all right, Dr. Woodson, this sounds great. I see there's a problem, but can you quantify it? What does that mean for me? So let's look at a couple of specific things. What about interfacility transfers? That's involving different healthcare entities. We're running it through a transfer center, and still 63% of our time is wasted on inefficient communication. Well, let's look at things like emergency response coordination. So these patients come in by multiple different ways. So some present by EMS, some show up at the emergency department in their personal vehicle, some are already inpatients, some are transferred, right? So these are basically many different ways, many different communication protocols and workflows, and they often involve multiple different healthcare entities. And so that's why you see 43% of the time is still wasted on inefficient communication during our emergency response coordinations. So you can look at other stats. 70% of treatment delays overall are identified as communication inefficiencies, as I alluded to earlier. Up to a third of malpractice cases come back with a sentinel event is miscommunication. And so at the end of the day, about 2% of all hospital revenues are lost, just thrown out the window, secondary to inefficient communication. So this is a big deal when we have limited dollars to provide care for our communities. And so when we start looking at the solution, what I'd like you to start thinking about is what is the value of uniting my people, my silo, my internal team with other providers that are on the care team, whether it's pre-hospital space and or interfacility team members. So obviously we've talked a lot about the problem. So what is the solution? So we believe the solution is a regional communication network for healthcare. So any patient with any condition involving any healthcare entity, they can simply create a dedicated patient channel, build a care team, and then communicate with each other. It's that simple. And it's got to be simple, and the teams have got to be dynamic. So we live, as Dr. Atkinson was saying, in a very complex world. In a complicated world, we could basically get a list of all the things that we need to do, all the team members check all the boxes, and then roll out a solution. That's not possible as complex of the problem as we have. And so a solution needs to be dynamic, it needs to be simple, it needs to be based on scalable adaptability, which is exactly what the solution is here. And so to kind of look at it a little bit more, and this will also kind of help define when and where do you need Pulsera. Pulsera can also be looked at as event-based real-time team communication that crosses healthcare entities. So you heard me kind of say the three things that we do. I'll dive into those a little bit more. So we create a dedicated patient channel. So just like when you have a disaster, you flip comms over to your disaster channel where everyone can talk about that disaster on one channel. We do that for every single patient. So for any patient with an event, we create a dedicated patient channel that can be used by anybody. Step two, you build your team. So you can build your team by adding a new healthcare entity. So that's like a new EMS agency or a new hospital. We can even add things like nursing homes and home health into the network. And that's especially important for ACOs and those type of situations. So within that entity, you can then add a team. An example of that would be like a STEMI team, a stroke team, a transplant team, a precipitous delivery team, on and on the list goes. Or you can add an individual. And then step 3 is you communicate. So there are 2 basic forms of communication. One form is called synchronous communication. That is where you do video calls or audio calls. It's where you can have a bi-directional conversation. It implies that both people are connected together at the same time, or groups of people are connected together at the same time. The other form of communication is called asynchronous communication. And that is, most people will be familiar with that with something like text messaging. And so in our platform, secure messaging, audio clips that can be listened to at a convenience, multimedia like photos, images, patient demographics, patient data like vital signs, labs, those type of things. So again, it's create a channel, build a team, and communicate. And so when you kind of look at the old way versus the new way, the old way is on that bottom line that you see. And so look at all the mixed technologies. We replace those with mobile technology. Studies actually show that 96% of physicians want their smartphone to be their primary communication device. So the next thing we do is we build that red line. When we start answering questions and talking later, we'll be talking more about what this red line is. And so we build that dedicated patient channel that anyone can use. Step 2, you build your team by adding a new healthcare entity, team, or individual. And then step 3 is you communicate. So all of that communication is held in that central communication hub. And one of the most radical things is you actually know who your team members are. So with one view, you can see who my team is, even if that team consists of people from other healthcare entities. You actually know the individuals and have one-touch access to do video calls with them, to do phone calls with them. You can put the information in that central communication hub that people can view it or pull that information when it's convenient for them. So the next thing, obviously, is really starting to dive into who Pulsera is. So our vision statement is to be the accepted evidence-based standard of care. As a part of our ongoing commitment, Pulsera is also an American Heart Association, American Stroke Association, get with a guidelines compatible vendor. We believe in data. We think this is very important. A lot of these organizations will really help support building regional systems of care. But what they do is they set up the infrastructure that needs to be there, from defining what teams need to be there, that kind of stuff. Where we come in, we can help leverage that work, come in and actually unite the people and let the people communicate with each other. So we actually encourage you to go online and look at our resource guide, where you can see all kinds of our case studies and publications and peer-reviewed journals. If you kind of do a meta-analysis on it, on average, we reduce treatment times about 28%. So I think it's important to also keep in mind that this is not emerging technology. This is not new. We're currently in 20 states in Australia. And I think this is very important as well. A lot of people think of us because they've known us as a STEMI and stroke program for years. But what we have done at Pulsera has been the last 5 years figuring out how to do this with hundreds of clients. So how do you actually build a regional system of care? That's a big deal. Not just the technology pieces of it, but how do you work with partners? How do you work with hospitals and EMS agencies for a plan to roll this out in your region? I think it's also important to understand, if you're dealing with team communication that crosses healthcare entities, everybody believes they're unique, right? Everybody has their own way of doing things. So how do you work in that system? How do you balance the need between pushing information and pulling information? How do you balance between alert fatigue and what would be appropriate interruptions in a workflow to drive the patient care that's needed? So we've used all this information over the years, and now we have a very robust video platform for any time-sensitive emergency. And we're now putting the resources into expanding the platform into the other states in other regions that we're not currently represented in. So one of our main jobs at Pulsera is to help you find the value. So I believe most of our clients out there do not view us as vendors. They truly view us as partners. So we're not here just to help you find value, which means identifying where can we help you improve your quality, where can we help you reduce your treatment costs, but it's also doing things like how do we roll this out in a region. So in some areas, for instance, people will start off with our pre-hospital communication package. We give all pre-hospital communication away for free to EMS, free to hospitals. No hidden agenda, no costs, besides putting an iPad in or leveraging a bring your own device policy in training costs. And the reason we do that is it helps unblock regions for what we believe is the real problem, which is a regional communication network. So we go into some areas where we start that way. We go into other areas where hospitals see intrinsic value in what we have to offer for their intrafacility and or interfacility communication. And so there are some areas where we basically will start off with that and EMS is not even involved. And obviously those are the two extremes. We can do anything in between as well. Our job is to work with you and your community and help figure out a way to basically convert from the old way of doing things to a regional communication network in your area. So we have a saying at Pulsera. You probably recognize the tagline, it's about people. We believe this very strongly, but especially when it comes to implementing new technology, we believe implementing new technology like this is 80% people, 15% process, and only 5% technology. Everyone spends a lot of time talking about the technology, but we believe that Pulsera technology is the future of communications in healthcare, but it's truly the people and the process that we surround around that that really sets us apart. So with that, I'm going to turn it back over to Bill for a couple of additional comments.
Okay, well, I just want to remind you that what Albert Einstein once said, we cannot solve our problems with the same thinking we used when we created them. And I think any of us that are long-timers in EMS, emergency services, hospitals, healthcare, and the overall emergency response in communities and across healthcare systems understand that we've had some great solutions to individual items, but the coordination of those solutions has been the problem. Next slide. When I was talking with Dr. Woodson and his team about sort of how's this look, I described the maze at the top, that the classic maze that every one of us that have worked in healthcare systems and EMS systems fully understand. You go in a lot of different directions, and I think about it like a heavy rescue situation when you start bringing in heavy response trucks in addition to, and teams in response to, in addition to engine companies and ambulances and the like. That's the same thing that happens in hospitals. The bigger the issue, the more complex the issue, the more people involved. And communication gets in a maze like you see here. The reality, what I think the folks at Pulsera are trying to accomplish is to bypass that maze and make it a direct communications, which still communicates across all the lines that need to be communicated with, but does so in a straightforward way. No ifs, ands, and buts about whether people are getting the message, because it's acknowledged when they do. Next slide.
All right. Well, thanks, Dr. Atkinson. So what we're going to do here, before we turn it over and go through general questions, we're going to kind of answer the top 3 questions that we get in almost every demo. So the first question is, does Pulsera integrate? The short answer to that is yes. So we can integrate into any major EHR. The second issue, though, is in the pre-hospital space. In the future, we are working on an API. We'll release an API that will allow any EPCR vendor to grab our data as well. So on the EHR side, the answer is yes. In the EPCR side, stay tuned. We are working on that. The next real question, and I'll spend a little bit of time on this. We've answered this a little bit in the past, but this is a different way of thinking, and so a lot of people will struggle with when and where do you use Pulsera. A lot of times the end users, the actual clinicians, it's a no-brainer. They see and understand exactly when and where they should use Pulsera versus one of their intra-facility communication tools or one of these CCNC type tools that we talked about earlier. But a lot of times administrators will struggle with when do we use Pulsera versus one of these other solutions that we've paid for. So I think it's important to take a step back, and Pulsera is used for event-based team communication, especially when resources are scattered. So if you can look up and see all of your resources in the same area and can holler at them, you don't need Pulsera. That being said, the main area, or one of the main areas that people will start using this is in the pre-hospital space. So we can replace the radio report, the patient report, almost in total. There are some conditions where it's helpful to have a bidirectional conversation in the pre-hospital space, the hospital space. They can leverage Pulsera to do even that, but a lot of times they can use the asynchronous communication. So we have a lot of areas, all pre-hospital communication can be done through Pulsera. So that means not just time-sensitive emergencies, but any condition. The other area, obviously, our specialty is uniting healthcare entities, so that are separate entities, meaning they don't even have to be a part of the same system. So interfacility communications, we can be used for that. So we assist, we don't replace, but we assist the transfer center in aligning the clinicians, and now they have a very scalable, very dynamic video platform that they can use, and the end users, the clinicians, it's something that they already carry in their pocket. So other areas that we're commonly used for are time-sensitive emergencies, STEMI, stroke, sepsis, trauma, cardiac arrest, pulmonary embolism. Those are the big ones, but also transplant, emergency C-section. The list can go on and on, where resources are scattered either within my organization in multiple departments, i.e. scattered around the hospital, but especially when it involves multiple different healthcare entities. And the reason why, even if you have an existing CCNC platform or intra-facility communication platform, a lot of people will use Pulsera. They prefer us for team communication, meaning that they really want to build a dynamic team and open up real-time team communication, especially for things like time-sensitive emergencies, because they don't want to have one way to do their job for patients that show up to the emergency department, and then another way if they show up by EMS or transferred. That's a very important point because it's human nature to want one way to do their job. Therefore, for time-sensitive emergencies, regardless of method of arrival, they have one way to do their job and coordinate their teams. So I think it's really important for you guys to know and understand these things. But at the end of the day, feel free to call us. We don't like shoving square pegs in round holes, and we're very happy to point out where our solution is better suited to manage versus where a different solution might be better for that scenario, that situation. So the third question that I'll answer before we get into the general Q&A session is, how much does Pulsera cost? And so we'll divide this up into a couple of areas. So the first thing, this is for all EMS agencies and all hospitals. Pre-hospital communication, excluding video, is free. So it's free to EMS and it's free to the hospital. So there's no hidden agenda. We're very forthright with why and where we do this. So we do it everywhere, and why is it unblocks a regional communication network. So go back to that example that we were discussing earlier, 30 hospitals, 60 EMS agencies, all the mixed technologies, especially when it comes to this scenario with the different EPCRs and different tools that we use and dashboards that we use. We give all of that away to unblock that in a metropolitan area. So all pre-hospital communication, free to EMS, free to hospitals, excluding the video components. So the next phase up is for hospitals. They have a couple of different options. So one option is what we call a pre-hospital plus package. So it includes obviously all pre-hospital communication, but it also includes interfacility transfers. It includes robust video. So this is typically for hospitals that are smaller. Often you think of in a hub and spoke model, these are your spokes. They don't have a lot of teams to mobilize within their organization, within their hospital. So this package is $850 a month for the hospital. Again, it's free to EMS. So that's a typical pre-hospital plus package when you would use it, that kind of stuff. The next one is the full version. So skip all the way through everything and say most expensive, all the bells and whistles, that kind of stuff. How much does Pulsera cost? So there is a one-time implementation fee, but if you look at our current average facility, it's right at $2,500 to $3,000 a month. That's how much Pulsera costs for our average facility. So obviously it will scale up or down a little bit depending on your facility, but that will give you a ballpark cost in what our average facilities are right now. So hopefully those were helpful. That's 3 of the most common questions that we get asked. So I will pause and we will allow the moderator to, we'll allow Mackenzie to give some additional instructions here.
Great. Well, thank you, Dr. Atkinson and Dr. Woodson, for that wonderful presentation. We'll now go ahead and begin today's question and answer session. So please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try to get through as many questions we have time for. And with that, I will turn it back over to you, Dr. Woodson.
Perfect. Thank you. And Hannah is going to be helping us manage the questions here, so she will be reading them.
Yeah, so we've gotten a few questions about the types of regions and entities that Pulsera supports. So this first question is kind of a combined multi-part version of that. So you said that Pulsera supports users in multiple different entities. So how do you structure directories to support this? And is there a limit to the size of the region that Pulsera can support? And is it designed more for metro or rural areas?
Perfect. Yes, we combined a couple of questions there, so we'll speak to those. So, pardon me. The back end is basically designed so that you can start with a case, whether it's an EMS entity or a hospital, and then when you're building your team, you basically add on a new healthcare entity. So it's an invite in. So you have to invite someone into your protected communication about this patient. So it is infinitely scalable. So we work with customers behind the scenes to make arrangements and relationships where you have certain EMS entities and or hospitals that you have relationships with. So there has to be an agreement to open that up on the before they're allowed, the actual clinicians are allowed to do so. So we help you manage that behind the scenes. So how big is the state or region or et cetera? So yes, we can involve situations as large as a state. A lot of times there will be RACs or regional advisory committees. Often they're set up for trauma in the past. Now they're assuming responsibilities for STEMI and stroke. They're really driving the process. We have other alliances that are out there that have common goals, often multiple hospital CEO representation, for example, and they will really push for their region. And again, it can be a small region all the way up to a state. And then on top of that, it can go down just to metropolitan areas or cities. And then it can go all the way down to very rural areas. So we can be used in metropolitan areas, but we can also be used in rural areas. So our vision is all EMS agencies, all hospitals help enable communications for a hub and spoke model.
Great. Next question from Maria is, what would the process look like for a centralized communication center moving patients from hospital to hospital?
So I believe that's really focused on something like a transfer center. And so if I understand that question correctly, then the way that a health system or hospital can set this up is you have a traditional transfer center, and we'll be happy to do a demonstration for you of what exactly this looks like. but instead of trying to connect people together, they basically are on the Pulsera app, so they communicate, a spoke facility can communicate with you via Pulsera. You can see what's needed. One tap builds your team by adding in the specialists that you need, and now they're connected. You can continue to be a part of this communication stream, so if they're asking you to mobilize these additional resources, et cetera, you can do that. But more importantly, it opens up a very dynamic video capabilities. And so they can push notifications directly to each other, so it doesn't totally have to be routed through you. That saves a lot of this middleman communication, but doesn't cut you out of the loop. I think that's very, very important. And so if you are on that red line, you get to have robust video capabilities with each other. There's no additional cost for the video capabilities. And so hopefully that helps describe how a transfer center would use it. We're not replacing bed boards or any of your current technologies that you're using.
Okay, so going along those lines, you said that this is a video platform, so who can use it, and can you tell us a little bit more about that?
Sure, and this is a difficult concept for people that are often used to the kind of the old way of doing things from a video perspective. So think of Pulsera more as HIPAA compliant FaceTime, for lack of a better term. That's an image that people can relate to, though. It's a HIPAA compliant video call. And so instead of doing phone calls, you basically can hit a button, and if you're on that red line, you have access to all of your team members. If they have video capabilities turned on, then they have a video icon. You just tap that button and it launches the video. So is that EMS to hospital? Yes, but that means EMS for medical control. It means EMS to the ED. It means EMS to the in-care specialist like a neurologist. Same thing for interfacility transfers. So I believe the analogy that I like to really give a lot is my daughter never, ever, ever calls my mom. Just, we don't do it. If we make a phone call, my mom is like, I want to see her. So we convert it over to a video call so they can see each other, talk to each other, all those type of things. The efficiencies that we can gain in healthcare by replacing a lot of phone calls with video calls, I think is tremendous. And that's the way this video platform will be used.
Perfect, thank you. So Sharon asks, on average, how long does it take to set up an EMS organization and hospital in an urban area?
Perfect, so it depends on the size of the urban area. I think it's real important. We again partner with you for this process. We very much believe in the 80-15-5 rule. It's 80% people, 15% process, and 5% technology. And so our job is to come in and work with your region and facility. What's the size of the metro area? How many hospitals? How many EMS agencies are starting out? What's the plan for expansion? All those type of things. And then we have a pre-implementation process that's very structured that we will work with you. In general, it's a 6-week or so process. Again, that's assuming all of the projects that are assigned and that kind of stuff are completed. Because it's very important to work on the people in the process and make sure they understand the why for the change. Because at the end of the day, the technology is a tool, and it's our job to make sure that you can leverage this tool. Now, as you're doing an expansion, like we've had an area that started off with all hospitals, 5 hospitals, 38 EMS agencies, flipped a switch, went live one day. We've had another area where it started with mostly a hospital, then they started adding on EMS agencies. So in an area that's already going, you don't have to have all EMS agencies on day one, because you can even start as a hospital, can start a case on their behalf. So if some of the EMS agencies call a radio report, a couple of taps and you can launch a case on their behalf. Bringing up those subsequent EMS agencies is very fast, very efficient. It's not the hospital's responsibility to do that. That's Pulsera, that's us. But we need the contacts, the relationships, that kind of stuff. So if you make those introductions, we will work on continuing to expand it out to, say you're a hub, we'll help you expand it out to your spokes as well as your EMS agencies. and especially bringing up the EMS agencies is very fast, very efficient, the subsequent ones.
Great. So Margaret asks, is this just for hospitals, MDs, and EMS? Do you include payers in this at all, or federally qualified health centers? I would assume payers with hospitals would want their own private network.
So again, this is real-time communication. So there are things like FQHCs and that kind of stuff. Any healthcare entity can come onto this platform. At this time, the answer to payers is no. We have talked to some payers before. There's interest in the data, that kind of stuff. But this is, we don't want to mix the data between the real-time communication. This is about uniting people. So who can come onto this network? EMS agencies, hospitals. We're now starting to bring nursing homes into the discussion, home health, people like ACOs that they're really trying to manage. Where is the best, most efficient place to deal with this patient? I need to create an event, have a conversation with a team, and decide what we need to do with this patient. Those type of healthcare entities can definitely come in here. But picture the app on your phone or on your iPad or Android device or whatever. Picture that as access into a communication network. That's how this technology should be used.
Great. Tim asks, are there any specific transactions that are currently done with fax machines, automated or facilitated by Pulsera?
Sure, yeah, so a fax is an image. And so there are things like transmission of ECGs that a lot of hospitals use if you're having a STEMI. They still use an ECG that's rolling off a fax machine. And so things like that we can replace. For interfacility transfers, there are other things that we can do. So instead of faxing face sheets, MOTs, some of these other things like insurance, that kind of stuff, just leverage the camera on the device. Just think of DocuSign and all these amazing tools that we have that you use images and it's PDFs actually, but you're leveraging the camera on your phone. That's what we can replace for things like interfacility transfers. So if you have a piece of paper, you can leverage the camera on the device, just like you do with DocuSign or any of these PDF converters, and you can leverage that on our platform.
Perfect. Anne was wondering, do you use this tool to coordinate a crisis situation such as an outbreak? Do you coordinate it with the executive leadership and the communication team, or is this strictly for clinical and patient treatment?
So for this question here, like this is really asking about disaster, MCIs, those type of things. So there are pieces to that. If you look at MCI and disaster, that is pulling all public safety together with healthcare resources. So EMS is the current bridge, one of the main bridges between that. So we are working that direction. The first phase is trauma. Trauma is coming out in the next few weeks, and so trauma will be there. And that's knowing and understanding what human resources we have at these facilities. It is our vision in the future to start to tackle more and more of MCI and or disaster management, because the same concept applies on the heavy public safety end, which is we often need a channel. We have multiple entities and multiple teams within those entities, and we all need to be able to communicate. So there's that piece of it. There's also the piece of combining those two scenarios together in patient identification, triage, those type of things. So we do a portion of that with the trauma app. We believe we will be working that direction.
Great. This next question is a little bit more about the technology side of things. So do you have to bring your own device to the hospital, or can clinicians use their own devices? And is this set up specifically for iOS and Android? And then the second part of the question is, what is the IT burden to implement Pulsera?
Perfect. Okay, so I'll try to answer all those quickly. So we can leverage a bring your own device policy. This is more of a question for the hospital and health system and EMS agency on what are their policies and procedures. But from a technical standpoint, we are fully HIPAA compliant and enable a bring your own device policy. So everything is encrypted, nothing is stored permanently on the device. We authenticate the users, on and on it goes, so we can enable a bring your own device policy. But there are hospitals and EMS agencies that prefer to supply devices. So all of the above work. In our experience, all of the above have been done and used. So there was a question in there about IT burden. So the IT burden is very light. There's obviously the upfront of evaluating our system, looking for compliance. Are they secure? All those assessments IT is obviously involved with. When it comes to the technical rollout of it, a lot of times clinicians are like STEMI coordinators, stroke coordinators, trauma coordinators. They're managing a lot of it. A lot of times it warrants an IT resource for project management and that kind of stuff. But relatively, it's extraordinarily light. It is a SaaS model, so we maintain all the upgrades and all the infrastructure and support and those type of things. If you do want integration, then there is a second level there, but this has immediate value to patients and to clients without integrations. We built it that way on purpose and spent many years making sure that you could flip a switch and go live, and it has intrinsic value without any integrations. So most of our prospects ask about integrations. Most of our customers prefer this data to be kind of firewalled back. They have 24/7, 365 access to all this data, but they kind of keep it quarantined in more of a QI, QA perspective. The last thing is iOS or Android. Yes, it is native on iOS or Android. We also have a browser version for EMS, and we're increasing browser-based capabilities for hospitals as well.
Perfect. We only have time for 3 more questions. So this next one says, of all of the things that you list to collaborate and communicate, who pays for integration for all of that, and what are the monthly fees?
So who pays for integration will be the hospital. It will be, it's very light. We use an integration partner who has a lot of relationships with a lot of these hospitals, and they have already done these integrations with all the different EHRs out there. And so when it comes to the cost, we will work with you on the cost. It's not like the integrations of yesterday, where these are outrageously expensive. The integrations are quite cost effective.
Great. Sharon wants to know if there are any state regulations that you need to overcome in order to implement Pulsera.
So there are different state regulations that have to be considered. In general, right now, we haven't really run into states that can't work with us. There are scenarios where the state would be needed because of the way they have their pre-hospital system set up to work with us, and they have to say it's okay. There are other areas where it's basically a conversation. There have been several areas where they thought there was going to be a barrier. We talked to the state and they see that it works very well. So we're basically enabling their current communications, but linking the pre-hospital community with their hospital care providers and not eliminating the need for communication. It's just changing the way they do it. So typically it's just a conversation.
Thank you. Okay, last question we have time for. If we're considering Pulsera, how can we evaluate the ROI for our specific facility?
Great question. So absolutely, please just reach out to us and we will work with you on a customized ROI for your facility. We'll help evaluate what's the value on the quality side of it, and also how can we help you reduce and eliminate either costs and or risk. So with that, I believe we are at the end of our time. We do ask you to reach out to us with any questions, comments. You can reach out to us online. There's an email listed there. We're happy to come to your facility as well and do a consultation to see if we're a good fit for your hospital, EMS agency, or region.